Dr. Kvedar, thank you so much for joining us today.
Well, I'm excited to have a chat with you, Jareen.
Yeah, me
Fun
too.
topic.
There's a lot of things changing in the world of healthcare, and CMS is driving a lot of that.
Hmm.
And so, we're going to talk a little bit today about some new codes that are proposed. So remote therapeutic monitoring. But before we get into that, I do want to introduce to our audience who you are. And Joe Kvedar, you are on our advisory committee, and you're very much involved in ClearArt Health. But before the internet and health trackers and apps or smartphones, Joe Kvedar was reinventing healthcare to move care from the clinic into daily life. Leveraging personal health technologies, Dr. Kvedar helps providers and patients manage chronic conditions, maintain health and wellness, and improve adherence, engagement, and outcomes. And I got all that from your website, joe.com. So I really appreciate having that at hand. So let's talk a little bit about the proposed codes for remote therapeutic monitoring. Can you give me a little bit of a background about those codes?
Sure. I have pretty good knowledge. I co-chair the AMA's Committee on Digital Medicine Reimbursement, and that started in 2017, I want to say. So we've been at it a few years. And one of the first things we did was put in what's called a code change application. And if we want, we can go into some of this detail or not. It might be arcane for some listeners, but some people might be interested. But anyway, we put in a code change application for remote patient monitoring codes. Those came out in 2019 and reimburse a doctor for three things related to RPM. One of them is the equipment itself. It's what's called a practice expense code. The second one is a reimbursement
on the bandwagon, and then you see it start tapering off. And so now it seems that a lot of provider groups are kind of reverting back to pre-COVID practices and a lot more face-to-face interactions. What's your take on that? Do you have a sense of, was it because we were filling the gap during COVID? Is it a lack of strategy for long-term adoption? And is there any concern with the AMA and CMS around, what are people going to continue to do? Because it sounds to me like CMS is definitely, they're adopting virtual care strategies all along. I mean, they're making it available. Yep. And is that being adopted and strategically planned into programs from provider and organization level?
Yeah, it's a great question. It's a complicated one. Mm-hmm. So I'll say a few things. I'll see if I can pull my thoughts together in a logical way. But from March to June of 2020 was an abnormal state. We were in lockdown around the country, and yes, telehealth blossomed, and that's a wonderful thing because now we can say that word and everyone knows what it means. That's a huge thing for the industry. But with that said, healthcare was never meant to be 100% virtual. And so after we entered the second phase in June, July of 2020, and even into today, not what we call hybrid, right? Where you have some options of seeing patients virtually and some in the office. And different organizations handle that differently. So it is, so I don't think before the pandemic, nobody really thought about it this way because the natural instinct was if you needed a doctor to go to a facility and see one. But we are, as healthcare providers, beholden to our investments in facilities. It just is the way it is. We have space. In a way, we're like hotels. People have to fill beds. If you come in, there's a little quirk in the system. If you come into the hospital and your doctor's office is within a certain physical structure related to the hospital, they can bill what's called a facility fee when you see your doctor. Separate fee goes to the hospital for using that facility. And again, people build these things up over the years. So if you create a vacuum around that, suddenly it's like, oh my gosh. And for sure, during that same period of time, March through June, provider organizations lost a ton of money because we weren't using our brick and mortar. So the reason I sort of lay it out that way is that and then the other thing that's happened in the meantime is, although CMS is bullish, and thank God they are, as you know, there's a lot more to healthcare reimbursement than what Medicare does. And if it's complicated and there isn't, more importantly, there isn't a clear horizon as to what it's going to be, then doctors are reluctant to make big investments in changing the way they provide care. It's going to be a cost a physician organization to retool so that, say, 30% of their volume is virtual. And then if they do all that and incur that cost and find out there isn't a reimbursement stream on the other end,
Sure.
that's unlikely. It's a very risk-averse environment. You know, the last thing I'll just say is there's a wild card now, which is called the Delta variant, and going back to doing more. So I think what I believe will happen, I believe that the public health emergency will be extended for some time, that the reimbursement practices, and I think you probably saw that in the physician fee schedule as well. CMS wants to extend them for a couple more years and quote unquote collect data about it.
Mm-hmm.
So, and then the last thing, I know I've been droning on, but this is all sort of comes together. The last thing is patients love this stuff, and you alluded to that. And so there's a market. If we as healthcare providers don't respond to that market, companies like Amazon, Best Buy, CVS just launched something, right? They're all out there waiting to capture the patient / consumer who wants virtual care. So I implore our provider colleagues to make some of those tough decisions, to take a little risk, to stay in the game. I could see a future where we become just the brick and mortar people. If you need an ICU bed, God forbid, or you need an operation, or you need an emergency room, we're there for you. That's a pretty small footprint compared to what we now consider our job. And it's a little scary to think of it that way, but that could happen if we're not smart about it. So probably more than you wanted to hear, but that's my thought on all that.
No, I think it's exactly what I needed to hear. And I'm pretty sure it's a lot of what our audience needs to hear, because there's questions about it. You know, you look at these curves and it's not simple to explain. And I appreciate the call out to, you know, fellow physicians. And it is taking a bit of a risk, but you're not wrong. As we transition into more and more consumerization of healthcare, people are wanting this. You know,
Yeah,
there's more than just CMS fee-for-service reimbursement. There's a lot on the table, and you know, we've all learned that there's another way to do things. And
that's
so
right.
now
Two channel now, yeah.
Yep.
The other thing to just quickly mention in that regard is sort of helps prove my point is there's something called a Fair Telehealth Tracker that probably you know about that, fairhealth.org. And the amount of claims coming in for telehealth is now pretty stable for the last few months at 4 to 5%. It varies a little bit, but it's pretty stable. Interestingly enough, and I follow this information is not, I can't cite it. The person who gave me this did ask me not to cite the company or the individual, but it's a large national payer, and they're seeing more and more claims coming in from the teledocs and the Amwells. So again, it just shows you that there's a market out there. If that provider sector decides that they want to retreat to brick and mortar, we might end up losing a fair amount of business long run if we're not thoughtful about it.
Well, I think from, you know, my perspective, a lot of the news and things that you're watching about what's happening state by state, job losses, people have exited their jobs on their own. And so a lot of people are going without health benefits. And so, you know, a lot of them have to access these other sources. So it's a reality. So I think we covered just about everything. So I want to thank you for a little bit of time to huddle and learn a little bit more. The world's curious. I mean, RTM codes sound pretty foreign today, and they're going to be our norm next year.
Well, that's right. And that is, we didn't spend time talking about AI or digital therapeutics. Those are the frontiers right now, is how do we reimburse for those two items? And that's spending a lot of time on that. They're both pretty thorny. And the RTM codes somewhat bleed into the area of digital therapeutics, because as I said, some of the things that can be reimbursed are software as a medical device. But the digital therapeutics companies are, I would say they're pretty aggressive, and I guess good for them. They have some good outcomes and they have a good case to make. The problem, I think, is that they call themselves therapeutics, and I go back to a standard therapeutic. If I write a prescription for Jareen, I don't get paid any extra for writing that prescription, right? That goes through the pharmacy benefit. So it is a little bit tricky. And then AI is even more tricky because all these reimbursement structures are designed to pay doctors for really on three axes: time, complexity, and practice expense. And since AI is designed to do things that you normally would do, like take a history or make a decision, I could spend less time with my patient, and we still haven't figured out how to, again, get the software paid for and so it's a pretty interesting world for sure.
No, there's so much more room for innovation. It's funny though, I'd had a conversation just earlier today about this, how much of the intelligence that you get from AI will reduce that physician's workload. And I know from my own, encounters with physicians, I had one particular cardiologist that always comes to mind. He has this description of working with a group full of students, and they're working with their patient, and their patient is on a tilt table, and all of the students are focusing on the computers in the room and the machines in the room, and the cardiologist, of course, with all the experience, is reading his patient, and he tells all the students, he asks the students, well, how's the patient doing? And the students are like,
looking at the chart.
And he goes, turn around, look at your patient. The patient's turning pasty and pale. And he says, you can't rely on every device, but it's the blend of the two. You have experience, instinct, there's people
judgment.
And every time you have people involved, things get a little bit different, so even the best written software application will always be a software application. And so there's always room for people. I, for one, appreciate my relationships with my doctors. So
yeah, amen to that.
Yeah. So thank you very much. I appreciate this. And I'll point everybody in the audience to joekvedar.com. They can learn more about the books you've written, and they can learn more about you and what you're up to. So point them in the direction.
Great to spend some time with you.
Yeah, good to spend time with you too. Thank you.
When